Hi, my name is Maria Kachaturian. I'm a family nurse practitioner student at United States University, class 572. Today's date is July 25th, 2025. I will be conducting a head, eye, ears, nose, throat exam. But before I do, I'll show you a 360 view of my workspace. Okay. All right. So, knock, knock. Hi, my name is Maria Kachaturian. I am a family nurse practitioner student at United States University. I will be conducting a head, eye, ear, nose, throat exam on you today. But before I do, I'd like to get your consent to record this and upload it on YouTube so my professor can grade it. Would that be okay?
Yes.
Wonderful. So I did my hand hygiene before I entered the room. Can I get your name and date of birth, please?
Argen Mastropian, February 13, 1987.
Wonderful. Thank you, Arget. And do you have any pain right now?
No.
Okay. And before we start, I'd like to let you know that if you at any point feel any discomfort, to let me know, and then we can stop the exam, okay? So we're going to go ahead and start. I'm going to start with inspecting the hair. I'm looking for texture, any distribution, any signs of thinning or hair loss. I'm also checking for hygiene and underlying scalp conditions like dandruff or lice. So I'm just going to look. Okay, the next step, I'm going to run my fingers through your hair. Again, I'm checking for same thing. So hair is straight, evenly distributed, no signs of thinning, and it's full. Next, I'm going to be inspecting the skull. I'm looking for shape, symmetry, for any trauma, rashes, any lesions or abnormal growth. So we're just going to look. And then the skull is normocephalic with no signs of trauma, rashes, or lesions. Next thing I'm going to do is I'm going to palpate the skull. So I'm checking for any cysts, any depression, any hematoma or abnormal masses that might not be visible. There you go. So no cysts, no lesions, depressions or hematomas noted, okay? Next thing I'm going to do is we're going to go down to the eyes. Do you wear any glasses or contacts?
No.
Okay, wonderful. I'm going to be testing the visual acuity using the handheld Snellen chart. So this is usually done in the office at about 6 feet, like two hands distance, and the wall one is about 20 feet. But for the purpose of this video, we're going to do it close up, okay? So what I'm going to have you do is cover one eye and read the smallest line you can see.
LTFPH.
And then one with the other eye.
LTFPH.
And then one with both eyes.
LTFPH.
Perfect. So visual acuities 20/20, right, left, and both eyes. The next thing I'm going to be doing is inspecting the eyes externally. So I'm just going to be looking, I'm looking for any symmetry, lid positioning, any swelling, ptosis, and abnormalities in the sclera and conjunctiva, which could suggest like an infection or a systemic disease. Next, I'm going to have the patient look up, and with my two thumbs, I'm going to pull down the bottom lids to inspect the sclera and conjunctiva. And have you look up. Perfect. And then the next thing I'm going to do is I'm going to go behind you, and then I'm going to be checking for exothalamus standing just like right behind you. And maybe look back and up. Perfect. Thank you so much. So no exothalamus noted. Sclera is white with no icterus. Conjunctiva is pink. No signs of excessive tearing, drying, or any swelling to the lacrimal glands. Both irises present, pupils intact, cornea clear. Okay. The next thing I'm going to be checking for pupil reaction to light. I'm going to both directly and consensually, which tests cranial nerves 2 and 3. Okay, and then in order to check the light reflex directly, I will need to have the patient look straight ahead, and then I'm going to flash the light in, okay? And then on the other eye, and then I'm going to check the other eye while flashing the other. Okay? Okay, so pupils are equal, round, and reactive to light. They constrict from 2 mm from 3 mm to 2 mm bilaterally. Okay, and then next I'm going to test cranial nerves 3, 4, and 6, which are oculomotor, trochlear, and abducens, by asking the patient to follow my fingers through the 6 cardinal directions. I'm watching for smooth motion, signs of nystagmus, which could indicate neurological or vestibular issues, okay? Now you follow my finger. 3, 3, 3, 3, 6, 6, and 4. Thank you so much. So no nystagmus was noted, extra ocular movements intact. Next, I'm checking convergence by moving my finger again towards the nose, which we already did. We're going to do it again. I'm watching if both eyes converge. Then I'll assess accommodation by having the patient look at a near object and then a far object. Pupils should constrict, then dilate accordingly, okay? So I'm going to have you follow my finger again. Perfect. And then I'm going to have you look at my finger. And then a far object. Perfect. So convergence is normal. Patient followed my finger at about like 5 centimeters. Pupils accommodate properly when shifting gaze. So next we're doing peripheral vision in all 4 quadrants, comparing the patient's field of vision to my own. It's called the static finger wiggle test. I'm going to be sitting in front of the patient at about arm's length away. And then let me have you cover your left eye. Perfect. Let me know when you can see my fingers, okay?
Yes.
Okay.
Yes. Yes.
Perfect. Now let's do the other eye.
Yes. Yes.
Okay.
Yes.
Okay, so we're going to do both eyes open when you're ready.
Yes.
Okay.
Yes. Yes.
Perfect. Thank you so much. So visual fields intact bilaterally. I'm using the ophthalmoscope to inspect internal eye structures, checking for the red reflex, which is the yellowish reddish haze bilaterally, optic disc and retinal vessels, and the macula. This helps detect any signs of glaucoma, papilla edema, or diabetic retinopathy. The optic disc is like a yellowish orange to creamy pink in color with sharp margins, and disc to cup ratio is 3:1. Arteries are light red, smaller, and bright. The veins are dark red, larger, and absent reflection with light. The macula off to the side and the fovea depressed in the center. For this exam, we would need to dim the lights, but however, for the purpose of this video, we're not going to dim it. So, so the first thing I'm going to do is look for the red reflex. Just look straight for me. Perfect. Now I'm going to put my hand up here for support. Perfect. Now I'm going to do the same for the other side. I'm going to look for the red reflex. Okay, and then I'm going to put my hand up here for support. so much. So red reflex present bilaterally. Optic disc is creamy pink with sharp margins. The disc to cup ratio is 3:1. Arteries and veins visualized. The macula is visible. The fovea is depressed. Next thing I'm going to do is inspect the ear. And if you can pull your hair back from me, please. So we're looking for erythema, asymmetry, discharge, or deformities that might suggest infection or any trauma. Okay. So ears are symmetrical, no erythema or discharge noted. And then we're gonna palpate your ears. So come here. I'm palpating to assess for any tenderness, which may indicate otitis externa or other localized issues. We're palpating the lobula, helix, and tragus here. So no tenderness noted, and no tenderness noted in the lobula, helix, and tragus. Okay. The next test we're going to do is assess for the gross hearing ability and cranial nerve number 8, vestibulo-ocular. I will have the patient cover one ear at a time, and I will stand at about like 2 feet and whisper a word to see if the patient can hear it. Okay, so I'm going to stand this side here, cover one ear. Thank you. 2F8.
2F8.
Perfect. Thank you so much. And then one on this side, if you can cover this ear.
2B8. 2B8.
Perfect. Thank you so much. Sorry. Hearing intact bilaterally. Next, we're going to be doing the Weber test. I will use the tuning fork to do this test. I will strike the tuning fork and then put it on top of her head in the midline. I'm testing to see if the patient hears the ringing stronger in one ear versus the other ear. So use my tuning fork, and then you're going to let me know if you can hear it, okay? Oh, sorry about that. So do you hear that? Okay. So the patient hears the ringing evenly in both ears, which is a normal finding. If heard greater on one side than the other, that would be considered lateralized, which could indicate a hearing loss. The next test I'm going to do is the Renee test. I will be striking the tuning fork and place it on the patient's mastoid bone, which is behind the ear here, the level of the canal. So we're going to just put it right here, and then have the patient let me know if they can hear it, okay? Do you hear that?
Yes.
And then let me know when you stop hearing it.
No.
Okay, so now I'm going to place the fork close to your ear and let me know if you can still hear it.
Yes.
Okay, perfect. And then we're going to do that on the other side. Let me know when you stop hearing it.
Mm-hmm. Now?
And then let me know if you hear it here.
Yes.
Okay. So since the patient still hears the sound, this is a normal finding, as the sound should be heard longer through the air conduction than through the bone conduction, okay? And then next I'm going to need to pull the patient's helix up and back. I'm going to use 2 fingers and place the bottom of my hand under the ear for support and safety. I'm going to displace the tragus with the speculum, okay? Perfect. Let me start with this in. So I'm going to inspect the external auditory canal and tympanic membrane for infection, wax, fluid, or perforation. Perfect. I'm going to do the next ear. Thank you. Perfect. Thank you so much. Okay, so both canals are clean, no erythema or edema. Tympanic membranes is pearly gray and intact. A cone of light visible at 5 o'clock and on right 7 o'clock. On the left, the landmarks such as incus and umbo are present. Just make sure my camera's on here. Okay, good. Next thing I'm gonna inspect is the nose. I'm checking for midline positioning and deformities. So I'm just inspecting. So nose is midline and no deformities noted. Next, I'm going to be palpating the nasal bridge and sinuses. The frontal, which is above the eyes, and then the maxillary, which is below your eyes. To detect tenderness or swelling suggestive like any sinus issues. Check here and here. So no tenderness or swelling over the sinuses. Next, I'm inspecting internal nose. I'm going to use my light to assess the nasal mucosa, turbinates, and septum for signs of like any infections, polyps, or structural issues. Let's check. I'm gonna come in here. Maybe look up a little bit. The mucosa is pink, no polyps or drainage noted, no septal deviation noted. We're testing the airflow and smell. I'm going to check for nasal patency and olfactory functions, which assesses cranial nerve number 1. I'm going to have the patient close one side of the nose and with her index finger, and then take a deep breath in. So I'm going to do it for both sides. So close one side, take a deep breath in. Now on the other side. Perfect. Thank you so much. Okay, so next I'll have her close her eyes and close one side of her nose and have her smell objects, and then she's going to let me know what she can smell. Let me know what you can smell. Coffee. Perfect. And then the other one? Light. Okay. So airflow unobstructed. I'm so sorry. Hands up. Your airflow unobstructed bilaterally, and smell is intact on both sides. Now I'm going to check the mouth and throat. I'm going to be inspecting the lips, the buccal mucosas, and gingiva for hydration, lesions, or signs of infection. I'm going to use a tongue depressor and light for this portion. So let's use my light. I don't have my tongue depressor, so that's okay. So first I'm going to inspect. And then now let me have you open your mouth. So your lips and mucosa are pink and moist. Gingiva is healthy and no signs of hyperplasia. So next I'm going to be checking the teeth and tongue. I'm going to look for any dentations, tongue size, symmetry, and and or any lesions. Assessing tongue strength for cranial nerve number 2. Okay. I'm going to have you open your mouth. Wonderful. Okay, so now I'm going to have you push against my hand with your tongue. Now the next one. Perfect. So good dentation. Tongue is midline, indicating in an intact cranial nerve number 12 with normal strength and no lesions. Okay. Next, I'm going to inspect the soft palate and the uvula for color, symmetry, elevation when the patient says ah. This assesses cranial nerve number 9 and 10. I'm also checking for pharynx and tonsils for any signs of infection or inflammation. So, have you open your mouth again and say ah. Okay. So soft palate and uvula is pink. Uvula rises midline with phonation. Pharynx is pink. Tonsils are at +1 bilaterally, and no cobblestones were noted. Next, I'm going to be checking for the neck. We're going to do a neck assessment. We're going to do range of motion, flexion and hyper extension. I'm going to have the patient lean the head forward and then back, and then have the patient turn the head to the right and the left, which are the lateral motions and rotations. So full roam is going to be checked. Let's have you lean forward and then back, and then to your sides, your left, or your right, and then your left. Okay. So full roam noted without any pain or limitations. Next, we are testing cranial nerve number 11 by having the patient shrug and turn head against resistance. Okay. Okay. I'm gonna go behind you again. I'm gonna have you shrug your shoulders. Okay. Perfect. Thank you. And then a spinal accessory nerve intact. Next, we are palpating all major cervical lymph nodes to check for any enlargements, tenderness, or fixity that might indicate any signs of trauma. Okay, so I'm gonna have you turn that way. Perfect. Thank you so much. Let's move your hair back. Okay. Can I just put it in?
Yeah, please.
Okay, perfect. So again, we're checking here. Okay, so preocular here, and then the submandibular here, and then submental here, and then the anterior cervical here, and then the posterior cervical here, 2 places. So here and here, and then the supraclavicular nodes here, and then the occipital back here. Okay, so no lymphadenopathy noted. Okay, next, thank you so much. Is it normally now? Okay, so next, when checking for trachea positioning, we are checking for any midline placement and movement with swallowing, which could indicate masses or goiter. I'm going to have the patient swallow for me, and I'm going to check. I'm going to have to swallow. Perfect. So trachea is midline and mobile. The next thing I'm going to have the patient do is first I'm going to inspect and then palpate the thyroid from behind. Let me have you sit that way.
Sorry.
No, you're okay. Okay, so I'm going to place my fingers here. I'm assessing for size, nodules, symmetry, and movement during swallowing. I'm going to have the patient swallow again when I tell you to swallow. Okay, go ahead. Swallow. Okay, again. So thyroid moves appropriately with swallowing and is symmetrical, and no nodules or swelling are present. And that concludes our exam. Thank you so much. I appreciate it.